Okay. Good evening, everyone. I'm Molly the Kush RN, and you've reached Conversations with Kush. Tonight, I am joined by two very special to me women, Jacqueline Higgins and Megan Mbengue, both incredibly accomplished nurses with a lot of initials behind their names. They are joining us tonight to talk about their study on CHS, Cannabis Hyperemesis syndrome. The study is being done in conjunction with Dr. Codi Peterson and Dr. Riley Kirk. Welcome, ladies, and thank you for being here.
Yeah, thank you for the invite.
Yeah.
Yes,
Awesome.
Thanks for having us. This is such an important topic. So
it really is. Yeah. Tell us, Megan, what is CHS?
CHS is, Jackie might have a better way of explaining it. CHS is this syndrome, this collection of symptoms that we see people who chronically use high amounts of THC with a genetic predisposition experience. And it includes, like when people are in an episode, it includes really intense and painful nausea, vomiting that is relieved by hot bathing. It includes this prodrome period that can be weeks or months before the first vomiting episode, where people wake up feeling nauseous. They have an intolerance to alcohol. And there's this other subset of prodrome symptoms. So it is this syndrome that people get from chronic use of THC.
Okay. Jackie, how did you get interested in CHS?
So I became interested in CHS when I was in school. And one of the things that you're always looking at and you're always curious about is what are the side effects of cannabis. But the issue for me is that I felt like there had been far too much bias going on anyway. And when I was reading about, adverse events and this kind of thing, there was this inflammatory component for me, right? So, and I think some of it was being concerned about what was being said in the literature. If you look at Benadryl, right, diphenhydramine,
yep,
and you take it in the morning and you're sedated all day, right, that's maybe an adverse event or a side effect you didn't want. But if you were to use that at night and you slept better, maybe that wasn't a problem. And so I was feeling that way when I was having conversations about side effects. Like sometimes they felt desirable and sometimes they didn't feel desirable. And so it was this navigating of the desirability of the experience, okay? The outcomes that people were having.
Of using cannabis.
Right?
Gotcha.
So in that, I wanted to know, what are the black box warnings? What is really an actual issue?
Sure.
And CHS was one of those, this is a very legitimate actual issue. So that is how I got very interested in it. And then I was like, well, okay, as a clinician, how do I diagnose this? Because, where does that come from? And I found the Rome diagnostic criteria. And I realized that it hadn't been around very long. It had been around maybe a year or two from the time I found it. So I was like, who knows about this? And that's when I decided to do the poster at ACNA because I was like, why not put it out there as a poster and just see what happens. And that's how I met Codi and those kinds of things. So it was a very different, it wasn't like I had encountered anybody with CHS. It was none of those things. It was really what are the legitimate problems that are these black box warnings that as a clinician you want to know, you want to be able to identify early and you want to be able to diagnose accurately.
And when you say black box warning, what does that mean for the people that might not know that?
So it's if you think about universal safety precautions, people universally would wear, gloves and a mask during a surgery, right? Yep. To make sure that you don't contaminate somebody's body. And so it's that kind of an idea, that level of true precaution, where do we really need to be concerned?
Right.
Yeah.
Okay. Thank you for explaining that.
Can I add on to Megan's thing? Because she did a beautiful job. And I want to just take us back to CHS. What is CHS? Of course. I think CHS is a diagnosis. Okay. And the issue with that diagnosis is it now has diagnostic criteria, which I just talked to you about.
Right.
So it didn't have diagnostic criteria. In fact, when it was first presented in the literature, it was presented as psychogenic vomiting.
Okay.
So for decades, we have not had accurate diagnoses happening. So we didn't have incidence, prevalence, those kinds of things. And I think that also makes this conversation more challenging because people are trying to understand, like, where did this CHS come from? I think it's been around. I don't think we had criteria so that people got diagnosed very specifically.
Sure.
And so, like if you have a blood pressure of 140/90, you are, help me out.
Hypertensive.
Correct, because that's a diagnostic criteria.
Right.
And so it's this whole idea of once you get quality diagnostic criteria, you really start to identify, and then you can actually say, the incidence isn't that high, right?
Sure.
We got 500 people who have this, and how many billion people do we have, right? So there's that kind of a thing versus, this is really actually more of an issue than we realized. And now that we have this criteria, we're seeing it more.
Yeah, for sure. And so the criteria are you need to have...
Oh gosh, you're going to make me do that. So the criteria, so it's the Rome for diagnostic criteria is what people are basing this on. And you're going to have to give me a minute because I don't know if I know them off the top of my head, but like, there's this stereotypical kind of episodic vomiting that happens. And it kind of matches cyclical vomiting syndrome.
Yes.
Okay. So that's one of the things, interesting controversy that's going on there with diagnostic criteria also. So just so that diagnostic criteria changes. Multiple sclerosis was being diagnosed well before we had MRI. Right. So diagnostic criteria changes as science and medicine change. Yeah. You have to be, I think, using cannabis for an extended period of time. We kind of have talked about it. And, what is the other one?
Oh, I know the big one. The big one.
What is it?
So first of all, like the criteria of it, like it's not exact. And there's also no billing code right now for CHS, which is wild. But one of the diagnostic criteria is that the symptoms go away after abstinence of 6 months.
Understood.
So you can't be diagnosed with it technically until like 6 months after you have stopped.
Or at least 3 cycles after being abstinent, right? So there's that whole thing. And then there was a group that was suggesting that the way, since we have, we don't have like a hammer so I can check your reflexes or a stethoscope so I can check your lungs. Like we don't have a great way to diagnose this. They were suggesting pairing it with urine toxicology so that you could demonstrate like the urine toxicology was negative and the person wasn't vomiting, and that was like kind of the best we could do. I think one of the things that's out there right now, because there was a small study that was done that looked at genetic markers, that was statistically significant. In people who were struggling with CHS, they had particular genetic markers. I believe there were like 5 genetic markers. Don't ask me what those are.
Codi talked a little bit on a previous episode.
So then the idea is, could we be looking at genetics in people that we are concerned might have CHS? And if they had these genetic markers, might that help to differentiate diagnoses? That study probably should be repeated. We don't usually do things on one study. So it would be, one of those things.
I can tell you that this is a big deal as an emergency nurse because of the way it makes people feel, right? Like people are using cannabis because it helps. Yeah. Or it's like the only thing that's helped after they've tried a myriad of things, with chronic illness or whatever it may, mental health issues, whatever that may be. It's the only thing that treats their symptoms. And so then for this thing to come about, I think it's devastating to people.
Very much.
First of all, it's painful, very painful. People feel as though they are dying. And, I've never had pain like, I guess maybe childbirth, I could relate it to that. But like, it's very distressing to people, I think, because they want to be able to use their medicine. And then every time they do, they get sick. And so that's hard. I've noticed an uptick in seeing cases of it in the emergency room, but maybe it's just more of an awareness, as you guys alluded to. Now we're starting to identify it a little bit faster. We're kind of queuing in and asking the right questions to people. So putting that all together, I think, is really helpful. And one thing that I love about this study is that this is really going to be tangible to the bedside nurse.
Yeah.
So I really appreciate that type of research and that type of thinking about, how we're looking at cannabis.
Yeah. Well, I think one of the things that the study really wants to do is elevate the voices of the people who are living with CHS.
Sure.
So this isn't like, where did CHS come from? Why are people having CHS? It's really about elevating those voices and allowing those voices to inform healthcare workers and, to allow for some take-home information that healthcare workers can then use with the really suffering human that is sitting in front of them or who is retching in front of them. I mean, it's this, right? I mean, it's that kind of a thing. Yeah.
I am looking forward to a tool that becomes developed, such as like a falls risk tool or, a wound staging tool for CHS. Because I think, again, as that's a tangible piece that a bedside nurse can do to be like, hey, do you have ABCD? And based on those answers, we can get to a quicker diagnosis and thus better treatment for a person.
Well, and also I'm going to add into that nurses are so good at getting information, right? They're beautiful historians. There is a strategy with how they communicate with people that helps people be at ease, and they share a little bit more with nurses, or they share differently with nurses.
Most trusted profession, Jackie.
So there's this way, and so nurses are crucial to history taking and really having quality information, especially as it relates to cannabis, because there's a very different conversation of somebody who used too much one time and is experiencing nausea and vomiting versus somebody who is, kind of a seasoned kind of cannabis person, right? And they have either been transitioning or escalating dose for any number of reasons, so it's a very different conversation, and that's a very different way to approach things.
Yeah, for sure.
Yeah, so nurses are crucial in that assessment piece.
Absolutely. How do you see the study helping or hindering patients then? What's the goal? What's the goal of the study?
I think, just like I said before, I think the goal of the study is to elevate the voices of the people who are living with CHS. Megan, what about you? What do you think?
I think the goal is to identify use patterns, symptoms, and treatment options. What we're asking people is like, how long have you used cannabis? When did you start your symptoms? Like in the 3 months prior to your symptoms, what were you using? Did you change your methods in those 3 months? And like the responses are fairly consistent that a lot of people are switching to vapes, like I'm not going to give numbers, but that's that was one of the options. And it's surprising how many people, it's not surprising, but a lot of people have switched to or use vapes or concentrates. So yeah, we're looking at the symptoms, we're looking at this prodrome, and then what treatment options work for people.
I'm sorry, just to clarify. So you're saying that if they present with CHS symptoms, their answer to that then is to switch to a vape? I'm sorry, I'm just trying to clarify.
No. Sorry, okay. I was not clear on that. One of the questions is like looking at the use patterns that people had prior to symptoms. And a lot of people, without giving any numbers, like a lot of people have put that they were already using vape concentrates or they had switched to the vape concentrates prior to their symptoms.
Understood. Okay. How do we treat it?
So one of the things is that CHS itself has phases, right? So we've talked a bit about the prodrome, which is really before anybody has kind of vomiting, right?
Okay.
And then if we go from there, we enter, people may not feel well. Interestingly enough, during the prodrome, it is common for people to increase use because they're trying to treat the symptoms, right?
Sure.
We all associate cannabis use with helping nausea and vomiting, not stimulating it, right? So it's this, it's this paradoxical effect that's happening. The the next phase would be the emetic phase, or this hyperemetic phase, where people are vomiting and vomiting and vomiting. And that is often when people will present to emergency departments because, of course, they become dehydrated.
Mm-hmm.
People will cramp up because they've lost so many electrolytes, right? Mm-hmm. That's when you can start seeing really some kidney injury, and that's when things are getting dangerous, right?
Okay.
The other thing is people are just looking for relief from the vomiting because it's so uncomfortable.
Sure.
And so it's during that hyperemetic phase when that's really like a very significant crisis period. Once you get kind of resolution of that emetic phase, which can just resolve on its own over, the course of, I think people have talked about, 3 to 4 days, but I've definitely heard of people talking about it for, 10 days. People talk about different experiences. Then people will go into this recovery period, and then there's this like interepisodic state.
Okay.
So this recovery period, kind of everything starts getting back to normal. They're being rehydrated, like those kinds of things. And then they have this period of quiescence where nothing is really happening and they don't really notice it anymore. And they're like, oh, I guess I was sick, or I guess I had the flu, or I guess, whatever that was kind of went away, or I must have kicked this, or I changed the way I was doing things. And so I'm okay now, those kinds of things. And then,
or like I took a tolerance break.
Right.
Yeah.
And then things kind of get ramped up again. So
Okay.
when we're talking about treatment, the question is what phase,
Sure.
right? And when we talk about symptoms, the question is what phase, right? Because there's this whole thing. So, if you were to catch somebody in the prodrome, really having a counseling kind of conversation about, this is starting to look like CHS, we might want to look at your cannabis use a little differently. Sure. And start having a conversation about that.
How would you counsel someone through that then?
Me?
Yeah.
Oh gosh. So if I was, I think the first thing I would have to do is build trust.
Yeah.
Because I don't think people often feel like
Sure.
And so it's the whole idea of really introducing the topic. And, did you know that this existed? Did you know that there were different phases? Would you be willing to look this up on your own? And so I'm more likely to encourage those kinds of conversations. Like, just think about how you're using and how much you're using, and look out into the world, because I don't want you to think I'm trying to mislead you.
Sure.
I think you want to walk a fine line in the medical community, because, since there has been so much bias, I think it's very difficult for people to feel confident.
Sure.
And so I approach it really with requesting that people start to learn.
Would you maybe suggest, would you present the information like, this is commonly, we see this in people that are using concentrates and high percentage THC?
I would present it as, this is what we currently understand.
Okay.
This is what has been cued, at least in the literature, And how could we do things differently? Because clearly we're having, if this is a medical conversation, I need to figure out, like, how am I going to treat a medical condition potentially differently, right?
Sure.
If this is, kind of a social conversation, then there's a conversation about social engagement and what that can look like. Because the other thing is, you don't want people to lose social context. There are things that become important, right?
Yeah.
So
such as?
I just think about this. Like, I baked cookies, right? Okay. Those cookies are gluten, dairy, and soy free.
Okay.
Like, I want you to think about that. That is not where people would have headed. Right. So in order to have a social engagement, I need to make sure I bake the cookies.
Yeah.
Right. So like and you have to navigate that. That takes a period of time to navigate, to understand, like, how do you do this? So I think people have to have those conversations and be willing to sit with people and understand, like, where are they getting their information? These are, are these trusted sources? Who am I coming into a relationship that has been built with a trusted source? So I think there's that piece.
Okay.
That's where I'm talking about.
Sure.
Do you want to talk about the emetic phase?
Please, let's talk about it.
Okay.
Thank you.
Because the emetic phase is a huge situation, because usual anti-emetic medications don't work.
Right.
So,
Reglan, Compazine,
don't work
Benadryl.
well. They all get tried.
Zofran.
But it becomes like these steps that people go through. What's in the literature that has some benefit? I mean, certainly IV fluids, right? Because we need to treat that immediate dehydration and whatever's happening with the electrolyte imbalance, right? But then the research says that haloperidol, so Haldol, and capsaicin topically are probably the most effective antiemetics at that point.
I'll definitely take that back when I see it. You know,
you're hitting the TRPV1 receptor, kind of like with people when they're showering nonstop, like they feel that compulsion to have that really hot scalding water. You know, and I mean, in the emergency room, you'd be looking for burns also, I would suspect.
Not too much. I think people get it. Like hot water might take my skin off. But one of the other things that we do see that works really well, though, too, is we do a lot of droperidol.
Oh, okay.
So that works somewhat, you know, and maybe it's just changing the perception of, you know, how the patient feels in the moment. I don't know.
Sometimes that's helpful.
Luckily, I think most of the people that get CHS, and maybe you guys can speak to this too, it's like a younger crowd, more so than, you know, like an older seasoned person that's been using cannabis for 30 years. You know, it's like more a younger type
the
of
literature
folks.
says like 16 to 34.
Yeah. And men, I feel like I see it more in men than I do in women also.
I feel like the literature also supports that.
Okay. Okay. Good.
Most
All right,
of the
so it's matching up.
Yes, it's matching up. It's always good.
Yeah, it does. Okay. So the emetic phase can be dangerous for people. So we recommend that you do get your electrolytes fixed, and, you know, you can use the host of medications that work. Capsaicin, like you said, would that be like rubbing it right onto the abdomen then?
Yeah.
Okay, gotcha.
I think that's where the studies were done.
Yeah. And I think, you know, that's where people hurt. Their stomachs just hurt.
Yeah.
You know? Awesome. What about that prodromal or the later phase then?
So the later phases, I feel like when people are in recovery, like there isn't
recovery phase.
The recovery. I don't feel like there's a lot to be said about that. Like they're just kind of, you know, there's this kind of rehydration, you know, I think we kind of understand like people are recovering. So, and then there's that inter-episodic where, you know, they may or may not be using, they may or not be having issues, which is one of the reasons why it's so difficult for people to buy into or to own, right? Because you have these, like, I got sick for a while, you know, I got better, you know, like we've had that throughout our lives, right? We got sick, we got better, we got sick, we got better.
Right.
So it's hard to realize that that's part of a cycle.
Gotcha.
And to recognize it. So sometimes it takes a few times before people really understand, like, oh, this is becoming a cycle or a thing. Yeah.
Well, and I wonder how many people are like, you know, okay, I guess I can't use cannabis anymore, you know, and really just have to go back to it because that's been the thing again, that's been working for them all this time.
Sure.
You know, because the recommendation, right, guys, is that you abstain for at least 6 months from cannabis completely to kind of clear all your receptors and make sure that, you know.
The recommendation is that you would never use cannabis again.
Again?
Correct.
So not even just like a 6-month tea break?
No.
Wow. Yeah. I mean,
that's the only treatment. That is the only treatment we have right now. Oh my gosh, it's a huge ask, right?
Ask,
so yeah.
What do you want to say about that, Megan?
So one of the nurses who's on our team has CHS, and she's been like monumental in helping us with this study. Awesome. She went undiagnosed for 8 years, and she has said, you know, and I think we're finding out in our study that the majority of people are continuing to use despite their diagnosis, despite their symptoms.
Sure.
But what she says is there's no use without some degree of symptoms, and people will report that like they can use again or they can't. So I think that it is individual. It's not something that we can say, go use again, you know, but I think that it is individual. And I think if people start to use again, they should steer clear of the high THC products. Sure. And go look at the other therapeutic cannabinoids to help manage their symptoms. And if they can use those without CHS symptoms, then that's fantastic.
Great segue. Great segue. And I think that's a really great point. There's so many cannabinoids that we have at our perusal that people can tap into that maybe will treat some of the symptoms that they've been using high dose THC for. So what kinds of things would you recommend in that case? I guess, would it just depend on the person? And how does that genetic component play a factor in that?
Yeah.
So I would like, so current, I mean, I would have, so from the diagnose, am I talking or are you talking? I'm sorry. Do you want to talk?
Megan, go ahead.
No, you go ahead first.
You go ahead.
I'm putting
you
up
go.
a little fire. You go.
I'm going. That's it. All right. So, from a clinician perspective, okay, the recommendation would be to completely stop.
Okay.
If I were to catch somebody in a prodrome where I felt, that would be a situation where I might be exploring different cannabinoids.
Okay, great.
Like to have a conversation about, let's get away from this. Let's see if this is less of a problem.
Sure.
But go ahead, Megan, because you had other thoughts on that.
I don't remember what they were.
About using different cannabinoids.
So I would imagine it would get down to like,
other
what
cannabinoids? I mean, we have to.
There's a delay. That's all.
We're running into a delay.
Go for it, Megan.
Okay. Other cannabinoids, post-diagnosis of CHS. CHS community would like come after me for saying this, but I think that it's again, like the lowest THC, if we're using THC at all, and then, looking at CBD and CBG, if they can use it without any sort of CHS symptoms. And plus that, like the acids and the terpenes, but in general, the consensus is to stay away, but we know people aren't doing that. So as harm reduction, if we're going to do it, then let's stay clear of the concentrates.
Okay. Sad. Sad that people have to, come to that point. And I'm really interested in if one of you could talk more about this genetic piece that you're looking at and like what you found so far and how genetics plays a role in this condition.
We didn't look at genetics.
No.
So no. That was a study that was done by Rousseau and colleagues.
Okay.
And so they had a group of people with CHS. They essentially compared them with specific dosing that they were kind of using. I think it was like 4 grams or something like that. And then they compared it with a control group that was using the same amount and was not having the symptoms of CHS. And they had marked genetic differences. And so that's why the genetics were statistically significant. The study was fairly small.
Okay.
And I forget how many. And so, the idea would be if we could repeat that study to get more information related to those genetic markers. Now, let's say you have somebody who comes into the emergency room and they're having this episode. If you used this tool, right? If it became a tool and it became a diagnostic tool, right? You could have an idea about whether or not the differential at that point is CHS versus CVS versus like cannabis withdrawal or those kinds of things. So I think those are the health conditions that people typically are trying to figure out is what is this?
Okay.
So there's that.
So CHS can mimic cyclic vomiting, you've mentioned. It can mimic CVS, which is...
cyclic vomiting.
Okay, so cyclic vomiting. What are the other things, Jackie?
Cannabis withdrawal. I think those are the 3 that everybody's trying to kind of figure out between.
Sure.
Yeah.
Okay.
And I think the withdrawal piece, if I can like touch on that, that's like one of the fascinating pieces of this that we've discovered along this way is like anecdote after anecdote of stories. Codi works in a pediatric ED, and then like me being on social media is people are reporting stories that like, okay, I went on vacation and I couldn't take my weed with me. And then day 2 to 3, I started having this severe nausea, vomiting, and ended up in the hospital with this cyclic nausea, like textbook CHS symptoms for a week. And so that's like this paradox here is like, is it withdrawal or is it CHS, or where's like that, the intersection of those? What's the difference between those? Because in our study, like a significant amount of people are saying that stopping their cannabis is triggering episodes.
Sure.
Which is like crazy
Yes.
how common I'm hearing that.
I want to just comment on that too. And I heard it was either Riley or Miyabi talking about the difficulties behind doing cannabis research. And because cannabis can be such an individualistic experience for people, it's difficult to study. And so talk about how you've navigated through that challenge specifically.
I mean, that's where like large mass survey data comes in, is
Sure.
being able to get these large numbers. Because if we have something that says X number of people report that cannabis withdrawal triggers a CHS episode, like that's significant. If we report that X number of people have like alcohol triggers their symptoms, and then like an alcohol intolerance is something that's not in the literature that I've seen. However, it's like, it is fairly common that people with CHS can't tolerate alcohol. And with the study, we're going to have that number to be able to, this concrete number to be able to put to that like this is a common characteristic across X number of CHS sufferers.
Sure.
Is this alcohol or this withdrawal? So I think that those are going to be, I forgot where I started with this, but
So just getting
repeating,
just
I think
getting
repeating,
the data points.
Right. I think repeating studies is important, right? So replication of data is always important.
Sure.
And then looking for, a good number of people to participate in a study is always kind of the goal. So, when you're talking about individuals and you have like an N of 1, because everybody's endocannabinoid system is as individual as their personality,
Exactly.
right? And so it can be a little bit challenging.
Sure.
But the human body is the human body, right? And so it responds in particular ways. I think the piece there is like what triggered one person might not be what's triggering another person. And that's the question is, are we diving into that and starting to get like little groups where we're hearing, or are we getting from a group or a large group consistent statements? And so I think that's the piece we're trying to figure out as we're hearing those voices.
Let's get you some more numbers in your study then. So who is a good candidate for this study?
yeah. Well, first of all, I'll say that like there are a number of CHS communities online, on Reddit, on Facebook, like tens of thousands of people.
Awesome.
However, our research team has been like blocked and stonewalled by these groups. So getting this data has been like so extremely difficult. Ethan Russo ran into this problem with his study on genetics, which is why that study was so small, because that group sabotaged his study.
What's the pushback, Megan?
You know what I would say? I think that what you're running into is it's a relatively unknown, right? Because there is stigma in the healthcare community. There is stigma in the cannabis community against people who would have CHS. And so the group is very insulated and very protective of the members in the group. And so it's that whole complexity of building trust, and for people to understand that the goal is to be supportive of the community and not to be negative against the community. And
Sure.
I feel like recruitment has been interesting because, as you listen to the barriers and you connect with the barriers, it's very interesting what people are saying. And they are being particularly protective and I think that's been fascinating to hear. I've felt like recruitment has just been fascinating in general. Would you agree, Megan?
Oh, 100%. Yeah. Recruitment.
Like Megan has been amazing with recruitment. And so I want to give her credit for that. But I don't know. Anything? Do you have anything else to add? I'm sorry.
Yeah. I mean, it's hard because in our team, we have hundreds of thousands of followers between all of us, but when you create a cannabis related video, it gets suppressed. It doesn't get pushed out the algorithm. So we've had people outside our team, like Tessa 420, big shout out to her. She has created content around this and like been able to get people signed up. So it's been like this like grassroots effort to get people signed up. And we are an all volunteer team. There is nobody else funding this study.
Yeah.
So we're not going to like pay for ads to people. So I think it's really important that people are, well, who paid for this study? We paid with our time, and our energy. So much time and energy went into this that went uncompensated.
Right.
The effort to help the CHS community. And I think there's like this, people don't realize that's our intention is to help the CHS community.
I'm struggling to understand why there would be pushback from people experiencing this. I would think that they would want it to be studied more in-depthly so that maybe there could become like some sort of resolution behind it other than just, sorry, you can't use cannabis anymore.
Right. And part of it is definitely ego. It's not everybody in the CHS community. It is the leaders of these groups, which is just the small handful of less than 5 people. Yeah. And if their name is not on this study or if they are not involved, they don't want us to access their community, even though their community wants to be involved. So it's,
one of the things that I have, run into, at different times in my career is, when there is a fix or a cure or a solution, sometimes people lose communities. So I think sometimes there can be a fear related to who am I if I'm not?
Sure.
And that's not to say people want to be ill or want other people to be, it's none of those things, but there can be these other things that go on that I think are completely unintentional. So, yeah.
So getting back to like who is a good candidate then, do you want to grab people when they're in the prodromal phase? Do you want to grab people after they've had an emetic phase? Do you want to grab them in that recovery /
yes
all of the things?
Yes.
Okay.
yes like that, it doesn't matter. It's like if you have been diagnosed, or I think the way the questioning is if you have been diagnosed or if you suspect it, because the other thing that you have is people are intelligent. They're reading, they're talking to people, they're trying to figure things out on their own. And that's a beautiful thing about human beings, right? Is we're very resourceful. And there, there's this whole push for wellness care rather than health care, right? Well care rather than health care. So I think I think there are folks who are probably at this point managing themselves.
Sure.
And so if they suspect, I believe that's a group. And certainly people who have like the formal diagnosis, right? Because we talked about, that piece as well.
So if you've noticed, audience, if you've noticed some things coming up through your own cannabis consumption, episodes of like nausea, arriving kind of out of the blue, or if you've actually had to go to the emergency department because you've had this intractable pain that's only resolved with a hot bath and, the host of drugs that we can give you at the emergency department and fluids, you may really want to tap into this and try to get down to the heart of it. And I think that this is an incredible study, and I really want to applaud you and thank you for this work, because the more we know, the better we do, right? And the better we can help people activate their own endogenous cannabinoids and make their own endocannabinoid system well. So thank you.
Yeah.
Yeah. Anything else that you want to add to it? We will definitely, when the show airs, be putting up the links to how you can become a part of the study if you would like to. So we will make that happen for you. Anything else either one of you ladies would like to add?
I guess the criteria for the study, 18 and up, have been diagnosed or think you have CHS. I think originally we said like have had a hyperemetic episode, but we're finding that people are filling it out and haven't quite had that hyperemetic episode yet. So that's totally fine. And I think quickly we can go through just like the prodrome symptoms that people can be on the lookout for.
Yeah, please do.
Waking up with nausea is I think the biggest one that most people experience. People with gastric reflux and heartburn really that wasn't there before cannabis use. This intolerance to alcohol. Alcohol is making people sick. Not like overdoing it with alcohol, but like 1 to 2 drinks is having them like wrapped around the toilet. Jackie, what else would you say are prodrome symptoms?
I think there can be nausea, abdominal pain. There might be a single episode of vomiting, not the hyperemetic phase where people are vomiting 6 times an hour kind of thing. I feel like
any other changes in GI symptoms like bowel movement stuff, or is it pretty much just upper?
I will say, some people have reported some weight loss, like if you listen to people out in the community, but that hasn't like been something that's talked about in the literature per se is weight loss. So
food intolerances.
Usually people are able to eat and those kinds of things. So like that, there's this ick feeling, right? Yeah. What about Megan? I think you covered a lot of it. Anything else you can think of?
Like the excess mucus production, that's something, as well as anxiety, anxiety that like wasn't there or that THC is making worse, I think could be an early sign.
So even their regular use has now, when it may have relaxed them before, now is starting to be kind of anxiety producing.
Right. And so then there's this desire to use more.
Sure.
Right?
Sure.
Okay. Yeah. So I think if there's this conversation where that people are feeling like, I just need to use more. I just need to use more. Or I just need to use something different. Or there's that.
How do people talk to their doctor about this?
Oh, I so desperately want people to talk to their doctor about this.
Me too.
How would they bring it up? I mean, I think you can, not all clinicians are versed in cannabis, right? So, or the endocannabinoid system. I mean, let's just go very basic, like the endocannabinoid system that we have, this whole body system. So this isn't something that has made its way into medical education, nursing education. I mean, I think nursing, there's a little bit more push in that direction. So there's a lot that's currently unknown. I think you have a conversation. You say, I want to talk to you about this. This is something I'm concerned about. I am happy to schedule an appointment the way you think I should schedule it. So, you're not trying to get this in a 10-minute visit, right? Yeah. I mean, I think people need a little bit more time. I think bringing any resources or offering any websites or asking your clinician, can we talk about this? Are there any labs you think I should do right now? Can I come back and have a conversation and be graceful, give them grace to have the time to, and recognize people don't know everything, right? I mean, I certainly don't know everything, right? Yeah. So there are times I've had to look at patients and be like, I don't know what that is. I have to look it up. Is that okay with you? And I have to tell you, people have been great about it. Nobody ever gets mad at me.
All the time.
Yeah, I have no idea. I have to look that up. Like, this is beyond me. I cannot speak intelligently.
Exactly.
And so I think allowing the grace of somebody to take the time to research something and look it up and recognize it may take a few visits. And it's a few visits that are not emergency department visits. Yeah. Right. That's that conversation.
And then conversely, how can healthcare workers and clinicians support their patients through this?
I honestly would like to see just more conversations in mainstream. Like in my practice, I bring cannabis up every day. Like I talk to patients about it. Are you using it? What's it looking like? Sure. Do you ever get any nausea or anything? Like I'm actually just actively having those conversations. while I'm, and how's the blood pressure and what's the blood sugar look like? And let's go over your labs. And so
For sure.
I just, it's just part of like the conversation. It's never been a Pandora's box for me. The Pandora's box is when it was thrust upon me many years ago. And I was like, oh my God, what is this? Right.
Yeah.
And I had to, that's a whole nother story. And I had to like really start to figure it out. But that is the learning curve. And I think it's surprising how easily it's incorporated in. Where you can almost start thinking about it as part of your review of systems.
One of the things I just really want to encourage clinicians and healthcare workers too is start using those diagnoses codes, because I think the faster and the sooner we're getting those into people's charts, the more that insurance companies are going to pay attention to that, and flags are going to be going off in hearts and minds like, okay, maybe this is something we really need to be paying more attention to. I think it will also open up research for those types of studies that are done just on collecting data, from blind studies and whatnot. So I think it's really important to start getting those things into charts, like cannabis without detriment, or whatever the diagnoses codes are out there. Just think about using those more often. And like I said, I think that will be a real good push.
Right. And also, I think we need to acknowledge like the potential for the overdiagnosis and jumping to the CHS conclusion.
Sure.
Because CHS is a diagnosis of exclusion, meaning we have ruled everything else out. Right. And so many people go in with these obscure GI symptoms. They have cannabis use on the chart or THC in their urine, and then the diagnosis is jump to CHS. And it's really something else going on. It is an ovary about to rupture. It's like some other organ or something else going on. So
good point.
There's definitely, and that's where our study will hopefully help kind of like narrow down those symptoms and help with the diagnosis.
Yeah. Again, really excited for this tool, guys, because I know you're thinking about it.
We are definitely thinking about it.
So bedside nurses definitely appreciate those types of things, So again, thank you, ladies.
Thank you.
I really appreciate your time. I appreciate your hard work and your dedication to this condition. And yes, thank you for what you do.
Thank you so much for having me.
All right. Have a great night.
You too.
So that's it for Conversations with Kush tonight. Remember to like, share, comment, and subscribe. And again, we will be posting the link if you'd like to become part of the